You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the Pre-Hospital Care podcast with myself, Owen Walker. In this episode, we're going to be speaking with Jason Killens on the future state of pre-hospital care. So what I wanted to do is examine the current state of the NHS ambulance services and how that's delivered within the UK. What we also wanted to do is look at the current models of operation and how that might evolve over the next 10 to 20 years and actually might need to be flipped on its head. So we're going to explore the numbers of see, treat and convey versus see, treat and refer versus telephone consult and close, and how this can be flipped on its head. We're also going to explore the adage of modern technology and how that can work to serve the needs of future patient care. And also the progressive Paramedic Career Framework and how this supports the potential referral pathways of the future. We're also going to explore some of the innovations that Jason initiated to work towards this goal. Jason Killens is the Chief Executive of the Welsh Ambulance Service NHS Trust. Also the custodian of what is a national provider of 999, 111 and non-emergency patient transport services for Wales. So he spent his career working in the ambulance service throughout the UK and Australia, and he progressed through the ranks in London Ambulance Service from an emergency medical technician to Chief Director of Operations. He was appointed as the Executive Director for the South Australian Ambulance Service in 2015 before joining the Welsh Ambulance Service as the Chief Executive in September 2018. Welcome to the podcast, Jason.
Good to see you. Good to be with you.
Jason, I wonder if we could just firstly look at your journey through the NHS to this current day.
Yeah, sure. So, I mean, as you touched on in the introduction, I joined the NHS, joined the London Ambulance Service in February 1996. It was the 26th of February 1996. I can remember my first day. I was 21. And after training as well, it was a QAP then, but essentially an emergency medical technician, EMT now. I was posted to East London, and I worked as a relief across East and North East London for a couple of years. So places like Whipps Cross, for those that are listening that are familiar with the geography, Whipps Cross, Leighton, Tottenham, as far up as kind of in North London up to Enfield, out to Romford, that kind of northeast quadrant. And I did that probably for about 4 years on the road. And I came off the road and went and worked initially in the resource centre, which was about, placing colleagues to shifts. And I really enjoyed that. And it kind of gave me an insight, I guess, into, other roles within the organisation. And after a short spell at Edmonton as an assistant station officer, I was promoted to station officer at 27. I went to Deptford in southeast London. Got a nosebleed as I went across the Thames to work in Deptford. And I was there for a couple of years, then went back to Hackney as same kind of job, but different title by then, ambulance operations manager. So Homerton, Hackney, City of London was the patch I had then. And after a couple of years there, went into a kind of a regional role, I guess, which was a performance improvement manager job. Assistant director for North East London in 2007, 2009. I went to headquarters, London Ambulance headquarters, as deputy director of operations. And then in 2013, as you said, was appointed executive director of operations. Did that for a couple of years and then left London with just about 20 years service and went overseas. And was the chief executive of one of the state ambulance services in Australia for 3 years, which was, good fun. Did all the expat stuff, barbecues, lived near the beach, all that kind of stuff. And then came back to the NHS weirdly because I missed it in September 2018. I've been here in Wales for just about 5 years now as the chief exec here. So 27 years in the ambulance sector, 3 services, 3 different countries. Loved every minute of it. Not a boring day amongst a lot.
So what I want to do is look at the ambulance service and look at sort of how we deliver care and how this might need to flip and change. But just before we do, I guess a personal question around your leadership, Jason, and sort of how maybe sort of you've changed as a CEO and leader over the past 5 years, because I think in your role and in sort of senior leadership, the transparency and oversight is far greater. So you get visibility into a lot more aspects than you might do out on the road. And indeed, that might change. And indeed, I'd be interested to know if that has sort of changed your perspective, indeed, as a person and as a leader.
Yeah, I would say dramatically. I mean, I wouldn't necessarily put a 5-year window on it. But I mean, if I think back now to, some of the things I was doing and thinking, when I was director of operations in London, I mean, I've said this openly before. There were some decisions and choices that we made back then, in the mid 2010s, that I look back on now and think, would I do those things now? No, is the answer. Now, of course, the circumstances were different, the context, you're operating in, but there are things which circumstances I think I would definitely act differently in and do things differently. I mean, I think if I think about, what I'm doing here now in this role for 5 years and what I was doing as my first appointment as a chief exec in Australia in 2015, I'm, very different. I think we all mature, don't we? Every day is a school day. I mean, we're all learning something every day, and I do genuinely believe that's true. So as time has gone on, we become, I think, more mature, more kind of measured in our choices and the decisions we make, certainly in the leadership space. I think the other one, I mean, I think about a previous chief exec that I worked for in London, who shall remain nameless. But I can remember conversations about, being authentic, being yourself, and, letting people, those which you work with, kind of letting them in a bit, being more personable. And that I found quite difficult back, mid 20s, 2015, kind of in that time period. Now, I suppose as, someone who's perhaps more confident, more settled in what I'm doing, more aware across a range of things, that is certainly easier. So I think I've, changed, matured, got a different perspective on things. Part of that is the role, part of that is the job and the role you're in. Part of that is our, ongoing learning every day. And I think, the other part of it is about how we mature, how we change as people over time.
And I would agree with that. And I would say in a senior leadership now myself, and having, like you said, matured to a place where become a little bit more conservative, far more willing to take other people's opinions, but also just be a little bit more slower in the approach, so to gather information. But I absolutely agree to that point. Jason, just flipping the conversation slightly and looking at the current state of activity, one of the elephants in the room from an ambulance service perspective is, and everyone knows this, whether it's verbalized or not, is that I would say upwards of 90% of pre-spot care is primary care. And that really has been a gradual but incremental and then exponential shift over the past few years. And that's no surprise to anyone working out on the road or dealing in pre-hospital care. And that tees me up for this question around the current state of activity, because it is primary care and still complex. There's complex patient needs. Could you maybe speak to what you see, and indeed these domains around sort of see, treat and convey versus see, treat and refer versus telephone consult? Could you speak to that?
Yeah, sure. So look, I mean, I'm known for somewhat controversial views. So let me just put this caveat on what I'm about to say. So I don't expect everyone to agree that's listening. I don't expect everyone that's listening to agree with what I say here. But over the last, you and I have seen this. And many people listening to this podcast that work in the sector, both here in the UK and internationally, will recognise this picture, which is that over the last 10, 20, 30 years, the way our communities use their emergency ambulance services has shifted significantly. The expectation of immediacy in terms of, provision of response, not just for the really sick patients that we go to, but all the other stuff as well. There's been changes, obviously, in how people can access, care in communities. Primary care is difficult to access, as we all know. So the way our services have changed. Our populations have got older, generally speaking, sweeping generalisation, but generally our populations, the communities we're serving, are older. Accessing primary care has got harder, and we've got more work because we've got a growing population. So activity is increasing year on year. And there are also shifts in the type of activity or the acuity of activity we're seeing. Now I would say, somewhat controversially perhaps, that the current model of ambulance service delivery, certainly here in the UK, which is largely, sweeping generalisation again, largely we get a 999 call, we listen to what's going on, we decide how important it is, and we go to scene. That's largely what we do. Yeah, that's been happening for 50 years. And I would say that the current model of service delivery is unsustainable. It's not affordable, it's unsustainable. It creates risk. I mean, we'll probably come on to kind of managing risk in the conversation, but in trying to service everything quickly, we create risk in itself, clinical risk. So I think for a range of reasons, those that I've just kind of, I guess, articulated, and the state of the urgent and emergency care system, certainly here in the UK, particularly where we've got, regions with extensive emergency department handover delays, which, generate that additional pressure and community delay, where there is significant avoidable harm and clinical risk, let alone all the issues it creates for our people. In that environment, I would say, and we certainly would say here in the service in Wales, that we have to dramatically change, truly transform the way we deliver care to our communities. And whilst, we've fiddled around the edges with hear and treat, see and treat, see, treat and convey, consult and close, whatever you want to call it, those are relatively small numbers in the scheme of the total activity we see. So our vision, for the next 3 to 5 years here, is essentially to flip the service model on its head. Now, again, these are sweeping kind of numbers, if you like, but they just share these numbers to kind of, I guess, try and articulate the scale of the challenge. If you said that currently we respond to about 80% of the work we get, roughly, that will vary across services. It will vary within services by region. But if you just said roughly we go to 80% of the work we get, our view is that in the future, we would only go to 20% of it, straight away. So we'd go quickly, and we guarantee a quick response to all of the work, which we all know needs a quick response: cardiac arrest, chest pain, stroke, cardiac chest pains, not all chest pains, cardiac chest pains, strokes, car crashes, all that stuff, we would go to quickly in that 20% bucket. Everything else, our view is that we would not turn a wheel. We would not seek to respond until it's had an upstream clinical assessment. That's not just by paramedics in our contact centres. That would be nurses. It might be, and some services are doing this already, mental health specialists. You might have pharmacists in there, a whole range of kind of clinicians, a multidisciplinary team, either employed by the ambulance service or that we access through arrangements with other providers, other health providers. And then only if we can't close that episode of care safely upstream with a clinical assessment, either on the phone or increasingly with video, with a video consultation, if we can't safely close or refer that episode of care somewhere else, would we then go to scene? And if we did need to go to scene and it wasn't in that 20%, in that really sick bucket, it would be with an advanced practitioner where we'd seek to close the episode of care in the community. Because I just don't think it's sustainable to continue to respond with a double-staffed, emergency ambulance to all of the activity we've got. So yeah, we've got quite a, I guess some might say, radical view about the future, but what's clear is the current model just cannot continue. It's not safe to carry on with what we've got as an approach.
So I completely agree, actually. And so we use AMPDS out here in Canada, but it's AMPDS is used in the UK, and there's no attribution of blame to that, but it isn't a nuanced tool. It's a tool. It's a tool. It's been historically used, but that almost creates the demographics of work, because that's the categorization tool. There is an over triage inbuilt, and it's empirically proven, but actually, to your point, it's not nuanced, and it's not. And actually, when you dig deeper into a lot of these cores, there is these details that you find out on scene. Actually, it's not as categorized, but also putting that upstream saves these resources. Now, again, we'll talk about risk shortly and how we stratify risk, but why is hear and treat coming to the fore versus this face-to-face consultation?
Yeah, well, look, I mean, we know, don't we? I mean, you again, in your introduction to the session, you indicated, our colleagues across emergency ambulance services or EMS services, not just in the UK but internationally too, are going to an increasing amount of social primary care, complex long-term conditions, not stuff that would be traditionally in the emergency ambulance space. And of course, as the skills, education, and knowledge of our workforce has changed over time, who'd have thought 10 years ago we'd have paramedics prescribing? It's a really good example. Who'd have thought 10 years ago that we'd have had paramedics out there with FP10 pads, writing out prescriptions? But we do. We were the first here in the UK to put them on the streets, but lots of services have got them now. So with those kind of changes, not only in our workforce and the stuff we can do, but also in our connection to the rest of the health system. So for argument's sake, 10 years ago, we wouldn't have been able to see a GP patient record. Well, we can now, and accrue, a clinician in a clinical contact center upstream can look into a patient's, GP record and see a whole bunch of stuff to inform their judgment that we just couldn't see 5 or 10 years ago. So with those advancements in those changes that are available to us, we're able to do different stuff, and manage, treat, respond, whatever you want to call it, differently to cohorts of work which traditionally we'd have had to go to scene for. So there is quite a lot of scope, we think, in our overall bucket of activity, which enables us to differentiate that based on the evidence, based on clinical evidence, not just the MPDS determinant or the pathways equivalent, but what we actually see when we get on scene. And of course, now with most services having an electronic patient record, we're able to interrogate that data much more rigorously than we were when we were all on paper with, PRFs. I'll show my age now, or LA4s as it was when I joined, a single A4 bit of paper. We've got much better intelligence now, so we can use that information, use that intelligence to redefine how we safely respond to patients. It makes sense. Yes, there's a load of stuff which is very different now to 10 years ago, which enables us to have a very different approach to the work we do.
It does make sense, and it's multifactorial. Like you said, the education's caught up, the workload has ever increased, and it's almost forced, I think, our hands to look at different ways in which we operate. Technology's improved, and we'll go there in a second. One of the things I'd like to go, one of the areas I'd like to go is managing risk, actually, Jason, and look at what perceived risks you foresee in this sort of flip model of care.
Well, look, I mean, I think the starting point has to be that there is risks in not changing the model of care. Yeah. So I talk about my own service here, because I can with authority on it, but I know this is a similar picture across many services in the UK. But we are holding, we're constantly holding work that we're unable to respond to. So these are emergency calls. None of this is a secret. It's well known. That can get in some services up to a couple of hundred deep. We've certainly seen that here. I know when I was in London, we would see that. You're familiar with that from when you were there as well. And sometimes these patients are waiting a very long time, and these are sick patients waiting a very long time. Patients that we'd be looking to get to in 14, 15, 20 minutes. We're waiting hours. So there is already risk in what we're seeing and doing now. And avoidable harm. I mean, let's be clear about it. There is avoidable harm happening now in our communities because we're unable to respond in a timely fashion. So seeking to service the activity in the way we do now is not without risk. That said, I do accept that, with any change and transition, of course, there is risk in the change. But what we can do is mitigate all that risk, because we can do it through improvement cycles. We can look at the evidence increasingly, as we've just touched on with electronic case cards, with connected healthcare records between primary care and acutes and so on, the single patient records. We can actually see what's going on. So the risk is more manageable, I would say, in a transition, or through the transition to change. And if we use the data we've got now in a smart and intelligent way to inform the choices we make about what we change and how we change it, arguably, that risk is diminished. So doing nothing is not without risk. Actually, doing nothing is not without significant risk, because it's there already. So I'm not persuaded by an argument that says don't change because there's risk in it. Well, yeah, there is. I accept that, but we can manage it. But what we're all struggling to manage is the day-to-day risk, which we know is there.
So looking at, I fundamentally agree with that, actually, and managing the current risk is like you said, but it's starting to become offset by the fact we can mitigate this with modern technology, with advances in technology. So a lot more face-to-face, well, not face-to-face, but digital consultation through platforms, and start to give the clinicians in the control room much more of a feel, a gestalt, being sort of a whole body review of what is happening with the patient. And even now within the Good Sam app and other apps, can start to get assessed respiratory rate, pulse rate, color of, mottling or diaphoresis. Could you maybe speak to how technology is and will support this flipped model of care?
Yeah, well, look, I mean, I will talk to technology. The other point I just want to perhaps touch on here as well is about our people. So the impact of doing nothing or changing on our workforce, on our people, on our clinicians, and not just clinicians, but colleagues in contact centres and those in corporate roles too. So, we know, don't we, that our people are deeply frustrated at the moment because many of them can't do the job they joined for, because they're, subject to delays at emergency departments because of pressure across urgent emergency care. We're contributing to that because we're taking a whole load of patients to the ED that arguably could be safely dealt with in some other way. And of course, we know, those delays at EDs means missed rest breaks, late finishes, frustration, skill decay, a whole load of stuff starts to emerge from that. So there is a duty on us as well, I think, to change, to improve the workplace experience for our people. And of course, in this kind of future model that I'm describing, with our people operating at the edge of their practice, of their scope of practice, we're empowering our clinicians to use the education and the skills that they've got. So the workplace experience for our people, our individual clinicians, is better as well. But on technology, I mean, I'd just give a couple of examples here. Most places have got personal issue tablets now for their staff. That's not just about electronic case cards. or patient reporting, as I've said, the clinicians are using those to access patient care records from primary care or a single patient record, dependent on where they are. We see opportunities for wearables. So there's a whole load of healthcare information in your Apple Watch or Fitbit or whatever it is that you've got. Well, how can we get hold of that? What in the next few years, could we be in a position where we're seeing that trending of basic kind of diagnostics, which will again inform a clinician's judgment about how they can treat a patient. You mentioned video technology. Who'd have thought 5 years ago we'd be having a video consultation with a patient in the street or in their front room? So things are constantly evolving and changing, and we need to exploit the opportunities that technology, ever changing and improving technology gives us in our sector. And it's not just about, I don't just think it's about sexy toys for our people to have. It's about how we can access information about patients, clearly with their consent, that informs the judgment of our clinicians and how we can respond, treat, manage an episode of care, rather than simply respond to scene and convey the patient to the emergency department.
So something in your model, Jason, is around, and is notion towards, but is very much a central piece. And one of my revelations is that actually alternative care pathways in the past, we heavily relied on external agencies to facilitate these pathways to make sure they worked. And the rate limiting steps were, if they didn't work, and GPs were overwhelmed, refer occupational health or rehabilitation services, COPD services were overwhelmed. The pathway didn't work. Yeah. One of the things I'm realizing now is with a single point of care model is that, and the ambulance services has had this revelation as well, is that if you employ those colleagues within a digital dispatch room, so it doesn't even need to be a physical one, it could be a meta dispatch room, they could be sitting in their front room, but
absolutely right,
essentially working for an ambulance service, so that the safeguard and the risk can be mitigated through technology. So I could have a face-to-face with you as a GP employed for the Welsh Ambulance Service, say, look, I've got this patient here, X, Y, and Z. But so actually the integration. So the rate limiting step isn't the non-functioning of a referral pathway, because we've integrated those clinicians so that we can stratify risk. But also, to your point, Jason, around what we're starting to do is see these urgent care ambassadors, these level 7 MSc trained, masters trained clinicians, which can also risk stratify with paramedics. So you on scene could talk to me in the control room. I might be an urgent care practitioner, and there's that level of safeguarding as well, and that never used to happen. That internal governance piece.
Absolutely right. So the upstream benefit of that senior clinical decision making and or support, shouldn't be underestimated, because it's not about disempowering clinicians on the streets or where they respond, but as you say, where there's a tricky job or one they're not too sure about, they've got that ability to reach back into the centre and talk to the mental health specialist or the advanced paramedic practitioner or whoever it is that's in the contact centre, who they need to get advice from to I guess confirm what they're doing. Your point about remote working, we've got clinicians now working in the remote environment away from our contact centres. You flippantly said in their front rooms, but we've got it. Who would have thought that 3 years ago, pre-pandemic, that wouldn't have been a thought that would have necessarily entered our mind. So we can access different types of clinicians or support now that we couldn't have been able to really access easily before, because we'd have had to have taken the patient to that clinician. Well, we can we can do that remotely now. And of course, it's better for our people as well, because if you think about flexible working, opportunities to work differently, different hours, different places in a different way. It's great for our people too.
So looking at, I think you've already notioned towards the risks if we don't change. And I think the risk if we do not change and adapt is that we disempower, disengage, and dissuade a large number of people from even entering the profession in the first place. Because like you said, from a grassroots perspective, and even indeed from a preceptorship and a mentorship, unless we have an agile ambulance service which is willing to change with the times and stream patients in different ways and mitigate risk, then you're not going to encourage people to come into the profession in the first place. So I take your earlier point and very much agree with it, that the risk to not changing is greater than the risk to the current operating model.
Yeah, I think that's absolutely right. I mean, the other thing the other thing we should reflect on people, on our workforce, is, that the mix of our workforce is very different now. 10, 20 years ago, it was largely male dominated. Well, it's, 50-50 there or thereabouts in terms of gender balance now. A lot of our people are coming direct entry through the university route. That wasn't happening 20 years ago. It was a vocational entry pathway. People 20 years ago, 10, 20 years ago, would join a service and probably stay with a service for a long time. That was because, then ambulance services were the sole employers of paramedics and emergency medical technicians. Well, that's not the case anymore, is it? There's competition. We're in a marketplace. We operate in a marketplace now, and rightly, our people spend a lot of time studying to acquire the knowledge and skills that they've got, and they're gonna move around the marketplace, aren't they? To Canada or to Australia. So we're in a marketplace. We have to be attractive and competitive, and part of that attraction is to work in a place, where our people can use the skills that and the knowledge that they've acquired to the max. And I would offer that simply sending an emergency ambulance with a paramedic and someone else to a scene and conveying a patient to an emergency department doesn't offer that opportunity for our people to stretch and grow. So there's a whole load of benefits, I think, in a quite a dramatic change to how we do it.
So, as an adaptive service and flexible, and indeed looking into the future, Jason, you've just appointed, or just about to appoint, a director of paramedicine within the service. And could you speak to how that might influence the trajectory of change, as opposed to maybe a medical director, or indeed just how you've come to that decision and what that might do for the future of paramedicine?
Yeah, so look, so we've had a director of paramedicine on our board here for probably about 2 years now, just over 2 years. A couple of other services in the UK have paramedics in director roles now, but we've got a director of paramedicine. So we've got a director responsible for nursing, quality, and safety. Currently got a medical director, but I'll come to that in a second. The reason that the board took the view that we wanted to have a director of paramedicine was simply around a triumvirate of kind of clinical leadership, so a doc, a nurse, and a paramedic, but also because we are different to other health institutions, other health organisations, in as much as our workforce are green shirt people. They're paramedics, they're emergency medical technicians, they're other clinical grades out in our communities, and it felt right for us that the profession had matured, developed, progressed, whichever language you want to use, over the last 15 or so years post-registration, to the point where they could increasingly become masters of their own destiny. We were less reliant on medical doctors, medical dominance, if you like. We were less reliant on that because we've got our own people that are sufficiently experienced and educated to be able to step into that role. So we appointed Andy Swinburne, who's our director of paramedicine here, just about 2 years ago, I think. And we've now taken the step where when our medical director retires at the end of this calendar year, I'm not going to get another medical director. Our clinical leadership here will be provided by Andy as Director of Paramedicine and Liam as our nurse. Now, we'll still have access to docs when we need them, and we'll still have docs in the organisation. But what we won't have is a doctor as a medical director on our board, and I won't have a doctor as part of my leadership team, part of the executive leadership team. So, a clear signal for me that paramedics can rise to senior clinical leadership roles if that's what they want to do, and that we think the profession has matured enough to a point where it's safe to do that. So we'll be the first ambulance service in the UK not to have a medical director. That's brave. Again, as with all these choices, it's not without risk, but it feels like the right thing to do.
And to your point, actually, Andy Swinburne, as a fantastic clinician himself, come through the ranks, appreciated the job from the ground up, being a jobbing paramedic through the ranks, but is, like you said, a real focus of attention so that people can, like you said, migrate, progress, and indeed attain a role as a director of paramedicine, so that there is that established pathway, and like I said, an appreciation. Having met Andy Swinburne myself, he's been in senior leadership positions for a number of years now, so he's got an appreciation of risk and an appreciation of the global picture. So it's having that exposure to leadership early on, or indeed through your career, so that you can come to it. Because as you said earlier, Jason, I think as you progress as a person and as a clinician, I think you tend to become a little bit more conservative as you go, a little bit less quick to act, more keen to listen and to read the room appropriately. And I think that probably maps across different domains of leadership as well. So it's fantastic to see, and it's aspirational for other services that have got their eyes on you. As we come to close, there's just a couple of more questions. One would be around rate limiting steps, and just what do you foresee? Because one of the things we've pointed to in this interview, Jason, is that we have to be the masters of our own domain in ambulance services. We are interconnected with other services, and we'll never get away from that. But fundamentally, there has to be a locus of control, an internal locus of control. And could you speak to some of the wider rate limiting steps that you see that constrain other ambulance services, and how they can maybe mitigate that?
Yeah, I mean, look, I agree with what you said there. Increasingly we have to find ways to respond and safely manage all of a broad church of the activity we see on our own. We always will be, should be, increasingly connected as part of the health system. We straddle the emergency services bit, don't we? But most of our work is in the single patient episode healthcare kind of space. So we increasingly need to be connected to the rest of the system, healthcare system, and social care actually as well. That's probably a whole nother topic. So rate limiting factors, I think, are around workforce. So most services, particularly in the UK, not so much in Australia and New Zealand, but certainly in the UK, are carrying large numbers of vacancies. Attrition is relatively high. For all the reasons, some of the reasons we've discussed already in this session, about the workplace experience for people, opportunities in the rest of the NHS, and so on. So there's, there is a rate limiter, I think, in supply of people. I think there's a rate limiter in the willingness of healthcare systems to change radically enough, and take risk, but managed and calculated risk. Back to the point we said earlier that doing nothing is also risky. So I think there's a rate limiter in the vision that a vision that people are coalesced around for what the future looks like. And I suppose the other one, is clearly an obvious one at the moment, which is around the need for investment. So improvement in outcomes and improvement in care, patient experience is going to need investment. Now, that's not to say that if we change our service model, we're really clear that, if we succeed in the vision that we have here, to flip the service model on its head, ultimately that saves the healthcare system money. Because we manage patients safely in the community. They don't get conveyed, they don't get admitted, they're not stuck in a bed. We haven't got all the bed blocking and access, but all that stuff goes away, or a lot of that stuff goes away. So investment upstream in the pre-hospital space can save secondary care, quite a lot of cash. But all the time there is pressure, and very extreme pressure in some places in secondary care, particularly in urgent and emergency care. It's difficult to get that investment out. It's difficult to get that money out. So a rate limiter for success, in a radical change in the pre-hospital space is investment. So it's probably it's 3 or 4 things in that that kind of come together to make rapid change, hard.
So as we come to a close, Jason, is there any sort of take-home messages you'd like to sort of give to listeners, just around maybe if there is listeners that are trying to progress and or enact change, and or see the changes that the Welsh Ambulance Service and that the board and indeed yourself are making, could you maybe speak to some take-home messages that you would infer to sort of facilitate that change?
Yeah. So probably a couple of things I'd say. I mean, look, be true to yourself. So, this is going to sound a bit corny, but, I joined 7 years ago to help people. And I still believe that now. I believe that's what I do. I believe now that every day I come to work or I get involved in something, I'm doing it because I'm trying to make it better for people. Now that doesn't necessarily mean we always get it right, because we don't. And part of the leadership challenge is to put your hands up and say when you've got it wrong, and that's okay. So I'd say, be true to yourself. Remember why you joined, which is to help people in most cases. I have a bit of a kind of a mantra, I suppose, where I kind of say when people ask me this, I say I feel like I lead by conviction. So what I mean by that is I do what feels right. Yeah. So that doesn't necessarily mean that when you decide or make a choice, inevitably you're going to upset some people. Yeah, that's just going to be the case. But when I make a choice, I do it because I believe it's right for the majority of the people involved. Now, that might be staff, it might be our people, it might be patients, it might be a mix of all of those. So you've got to do what you believe to be right, I think. Remember why you joined, do what you believe to be right. Don't be afraid to try new stuff, take some risk, and I guess the fourth one, the final one probably, would be, you won't always get it right, and that's okay. Just say so. Just say you got it wrong, but importantly, put it right. Understand why it went wrong and put it right. So 3 or 4 things, I guess, there that are relatively basic, but I think important to hang on to. And it's easy for those to be missed, or for you to forget those when you get into the heat of battle with competing demands and pressure from stakeholders, commissioners, staff, unions, those you work with. It's difficult for some of those things to hang on to some of those things.
Fantastic. That's fantastic. Thank you, Jason. Thank you for your time today and just your reflections. Thank you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.